So let me tell you the oral preparations of the iron. Oral preparations, they include number 1, the ferrous sulfate, right? Number 2, the ferrous gluconate, and then we have ferrous succinate. So these are the oral iron preparations, right? Ferrous sulfate, gluconate, and as well as the succinate. Now out of which you take this ferrous sulfate. Ferrous sulfate, it contains 20% of the elemental iron. Right, it contains 20% of the elemental iron, and for the treatment of iron deficiency, the dosage recommended is 200 milligrams elemental iron daily. Right, for the treatment of iron deficiency anemia, how much amount of elemental iron is required? You require almost 200 milligrams of elemental iron daily, and this can be obtained by giving 1000 milligrams of the ferrous sulfate, because right, in ferrous sulfate how much is the elemental iron? It is only 20%, right? And how much is the recommended dose of the elemental iron? That is 200 milligrams of elemental iron is required. So in order to obtain 200 milligrams of, right, in order to obtain 200 milligrams of the elemental iron, this will be obtained from, so this 200 milligrams of elemental iron, it is obtained by giving 1000 milligrams of the ferrous sulfate, right? 1000 milligrams of the ferrous sulfate, and this particular ferrous sulfate, it is divided in 3 doses, right? It is divided in 3 doses. Why it is divided in 3 doses? Because the tolerability is also very important, right? So this dosage, right, this dosage is divided into 3 doses. By providing around 60 milligrams of iron per dose, right, you require how much? 200 milligrams of elemental iron. So you give 60 milligrams per dose, right? That will be around 180 milligrams to 200 milligrams. Okay, because that is a maximum tolerable dose. 60 milligrams is a maximum tolerable dose, right? Now this particular iron absorption, what are the factors which will affect the iron absorption? That is the presence of the low iron stores, right? So if you see the iron absorption, right, the iron absorption, it increases in response to number 1, low iron stores. So when there is low iron stores, the compensatory mechanism is that the iron absorption increases across the duodenum in order to meet the demand. In order to meet the demand. So iron absorption increases in response to low iron stores or increased iron requirements. So whenever there is increased iron requirements, right, whenever there is increased iron requirement, then also the iron absorption increases. Now what are the clinical scenarios where there is increased iron requirement? Right, you take pregnant female, right, lactating female, there is increased iron requirement, so even the iron absorption also increases. Now once you start giving the ferrous sulfate in patients with iron deficiency anemia, how will you assess the response? How will you assess the response? You need to check the reticulocyte count. Alright, this reticulocyte count should begin to increase in 2 weeks. Okay, So how will you assess the response? Right, you will assess the response by measuring the reticulocyte count. Reticulocyte count, it will begin to increase in 2 weeks. Right, it begins to increase in 2 weeks and it reaches the peak value within 4 weeks. Right, it reaches the peak value in 4 weeks. So once the reticulocyte count is increasing, this suggests a good response to treatment. Right, this suggests a good response to treatment, and treatment with oral iron should be continued for 3 to 6 months. Right, this oral iron formulation, that is ferrous sulfate, this should continue. Right, this should continue for 3 to 6 months, and this will correct the anemia and replenish the iron stores. Right, whenever you are giving for 3 to 6 months, this will correct the anemia. So what should be your target? Your target is not just only correcting the anemia, you should also replenish the iron stores. Right, you should also replenish the iron stores. Right, and apart from the reticulocyte count, you take the hemoglobin level. The rise of hemoglobin level of blood by 0.5 to 1 gram per deciliter per week is considered adequate response to iron therapy. Right, not only the reticulocyte count which will assess the response, even the rise in the hemoglobin. And what should be the rise in hemoglobin level of the blood? That should be around 0.5 to 1 gram per deciliter. Per week. Okay, so this is considered as adequate response to iron therapy. And for prophylaxis of iron deficiency, 200 milligrams ferrous sulfate once daily is enough for prophylaxis. Right, for prophylaxis of iron deficiency, 200 milligrams of the ferrous sulfate once daily is enough. In pregnancy, iron should be started in second trimester. So I said you, right, there are certain scenarios where there is increased requirement, and that is, one among that is pregnancy. So when should you start the iron supplementation? The iron supplementation should be started in the second trimester. Right, it should be started in the second trimester. Right, and what will be the major adverse effects of this oral iron? Major adverse effects of oral iron is that they will develop or they will have gastrointestinal problems. Okay, so if you see the adverse effects, okay, so before going on to the adverse effects, let me shortly recap like what I have discussed. The iron formulations, like we have ferrous sulfate, gluconate and succinate, and out of that, if you take the ferrous sulfate, you know, like it contains 20% of the elemental iron, right, 20% of the elemental iron. So in iron deficiency anemia, you require almost like 200 milligrams of elemental iron. So in order to replenish this 200 milligrams of elemental iron, you need to give 1000 milligrams of the ferrous sulfate, and that is given in 3 divided doses, providing around 60 milligrams elemental iron per dose. And iron absorption increases in response to low iron stores, and it also increases in response to increased iron requirement. And how will you assess the response? It is the reticulocyte count. Reticulocyte count should begin to increase in 2 weeks. It will reach the peak in 4 weeks. This suggests a good response to treatment. And treatment with oral iron should be given for nearly around 3 to 6 months. Why? This will not only correct the anemia, but this will also replenish the iron stores. And not only the reticulocyte count, even the rise of hemoglobin level of the blood by 0.5 to 1 gram per deciliter per week is considered adequate response to iron therapy. right, adequate response to iron therapy. And for prophylaxis of iron deficiency, 200 milligrams ferrous sulfate once daily is enough. And in pregnancy, iron should be started in the second trimester. Now, let me discuss the adverse effects and as well as the other formulations of the iron. So, if you take the major adverse effects of the oral iron therapy, major adverse effects of oral iron therapy that results in poor compliance are the gastrointestinal problems. Okay, so the major adverse effects of the oral iron therapy is right, that is the gastrointestinal problems. And this particular gastrointestinal problems, they include number 1, epigastric pain, right, epigastric pain. Number 2, nausea, vomiting, and then metallic taste, right, and then metallic taste. So these are the gastrointestinal problems that can happen upon the oral formulations of iron. And the severity of these gastrointestinal problems, these are related to elemental iron content, right? The severity, it is related to right, CVRT, it is related to elemental iron content in the iron preparation. Now, apart from the adverse effects, apart from this ferrous sulfate, succinate and as well as the iron formulations, we have one more oral iron formulation, that is ferrous citrate, right, ferrous citrate. Now, what is the advantage of this ferrous citrate? Let me tell you. This ferrous citrate, it has the capacity to bind phosphate, right? This has the capacity to bind to the phosphate. Now, after the ferrous citrate is bound to the phosphate, this will result in a non-absorbable complex. Right, this will result in the formation of a non-absorbable complex. Now, what is the advantage of the ferrous citrate? You need to know there are certain clinical conditions where you can have the development of hyperphosphatemia. What are those conditions where you will have the hyperphosphatemia? Right, that is in patients with the chronic kidney disease. See, in chronic kidney disease, the glomerular filtration rate is reduced. So there will be reduced GFR. So because there is reduced GFR, the phosphate is not excreted out. That will result in the hyperphosphatemia. So in chronic kidney disease patients, in order to control the hyperphosphatemia, you can give this formulation, that is ferrous citrate. And this ferrous citrate, it is also an oral iron formulation, right? So until now, what I have discussed is only the oral iron formulations. Right, and these oral iron formulations, they include number 1, ferrous sulfate, ferrous gluconate and ferrous succinate. And then we have ferrous citrate. It has an added advantage of controlling the hyperphosphatemia in patients with the chronic kidney disease. Now, after having discussed about the oral iron formulations, let me tell you parenteral iron preparations. So, what are the examples of your parenteral iron preparations? The parenteral iron preparations, they include Iron Dextran, right, Iron Dextran. Second, we have iron sorbitol citrate. and the last one is FCM, right? So this FCM is a new drug, right, and it will increase the iron rapidly and which helps in adequate erythropoiesis, okay, and this FCM stands for, so this FCM stands for Ferric Carboxymaltose. So these are the parenteral iron preparations. Now let me discuss about this parenteral iron preparations. So if you take the parenteral iron preparations, the parenteral iron preparations are the Iron Dextran, right, and the other important formulation is iron sorbitol citrate. Then lastly we have FCM, right, that is Ferric Carboxymaltose. So if you take the routes of administration of these drugs, you take the Iron Dextran. This can be given either intravenous or the intramuscular route, right, it is given either intravenous or the intramuscular route, whereas the later one, that is iron sorbitol citrate, it is given only via the intramuscular route. Now why it should not be given through the intravenous route, right? So this iron sorbitol citrate, it should never be given through the intravenous route. Now the question is why? Because this iron sorbitol citrate, it will cause rapid saturation of the transferrin receptors, right? Whenever you give through the intravenous route, it will cause rapid saturation of transferrin receptors. Right, it will cause the rapid saturation of the transferrin receptors, and this can cause the iron toxicity, right? This will cause the iron toxicity due to more free iron, okay? So that is the reason why it should never be given through the intravenous route. And Ferric Carboxymaltose, it is given through the intravenous route. And this is mainly given in individuals with anemia, with heart failure. So anemia, it can cause high output heart failure. So in that clinical scenario, you have to give this FCM, that is Ferric Carboxymaltose. Then followed by that, how do you calculate the total iron requirement? So there is a formula for assessing the total iron requirement. So the formula for the total iron requirement is 4.3 multiplied by body weight of the individual in kgs, right, and that should be multiplied by the hemoglobin deficit, right, that should be multiplied by hemoglobin deficit, and this hemoglobin deficit, it is taken in grams per deciliter. So this is how you will calculate the total iron requirement, and the importance of this formula is that this formula will calculate the iron deficiency anemia, that is like what is the requirement of iron for the treatment of iron deficiency anemia, and it also calculates the replenishment of the stores, right, it also calculates the replenishments of the stores. And whenever you are giving this intramuscular route of administration, this intramuscular route of administration should be given in the form of Z technique. Now, what is the importance of this Z technique and why is that you need to give via Z technique? See, the purpose of giving this intramuscular injection of iron by Z technique is mainly to avoid staining and pigmentation of the skin, right, mainly to avoid staining and mainly to avoid staining and pigmentation of the skin. Now, what are the major problems with the parenteral route? So, whenever you are giving drugs, right, whenever you are giving drugs through the parenteral route, the major problems with parenteral route is pain at the injection site, right? Pain at the injection site. And the second important thing is pigmentation of the skin. Right, pigmentation of the skin. So this will be the main problems whenever you are giving this iron formulations through the parenteral route. Now let me tell you the differences between the iron dextran and as well as the iron sorbitol citrate. So on one side you take iron dextran and on other side you take this iron sorbitol citrate. So if you take this iron dextran, it can be given through both the routes, that is intravenous route or the intramuscular route. But whereas if you take this iron sorbitol citrate, it has to be given only through the intramuscular route. It should never be given through intravenous route. And if you take this iron dextran, it is not excreted. Right, it is not excreted. But whereas the iron sorbitol citrate, about 30% of it is excreted in the urine. Right, about 30% of it is excreted in the urine. Then this iron dextran, it is absorbed through the lymphatics. Right, it is absorbed through the lymphatics and it is not bound to transferrin. Right, it is not bound to the transferrin, whereas iron sorbitol citrate, it is absorbed directly into the circulation. Right, this is absorbed into the lymphatics, whereas iron sorbitol citrate, it is absorbed directly into the circulation. Right, it is absorbed directly into the circulation and it is not bound to transferrin. Right, it is not bound to the transferrin. Okay, so that is about the importance of the iron sorbitol citrate and as well as the iron dextran. Now after having discussed about the parenteral preparations of iron, let me tell you about the iron poisoning. So let me just have a short recap of this parenteral preparations. The parenteral preparations, we have the iron dextran and as well as the iron sorbitol citrate and ferric carboxymaltose. And this iron dextran, it is given through intravenous or intramuscular route, whereas the iron sorbitol citrate, it has to be given only through intramuscular route and it should never be given through intravenous route. Why? Because it will cause rapid saturation of transferrin receptors, which can cause iron toxicity due to more free iron. And how do you calculate the total iron requirement? This can be calculated by the formula 4.3 multiplied by body weight of the individual in kgs multiplied by hemoglobin deficit, that is grams per deciliter. And this formula includes the iron required for replenishment of iron stores also. And the intramuscular formulations, the intramuscular injections are usually given by Z technique, that is mainly to avoid staining and pigmentation of the skin. And major problem with the parenteral route is pain at the injection site and pigmentation of the skin. And if you see the differences between iron dextran and as well as the iron sorbitol citrate, iron dextran, it can be given via intravenous or intramuscular route, whereas iron sorbitol citrate only intramuscular route. And iron dextran, it is not at all excreted, whereas iron sorbitol citrate 30% of it is excreted in the urine. And iron dextran, it is absorbed through lymphatics, whereas the iron sorbitol citrate directly it enters into the circulation. And iron dextran, it is not bound to the transferrin, whereas iron sorbitol citrate, this is also not bound to the transferrin. So this is about the parenteral preparations. Now next let me take up the discussion of the iron poisoning. So after having discussed about the iron preparations, that is oral and parenteral preparations, let me discuss about the iron poisoning. So iron poisoning, it can be in two forms, either it is acute iron poisoning or the chronic iron poisoning. So let me discuss acute iron poisoning. So if you take this acute iron poisoning, it can occur in children due to accidental intake of large number of iron tablets, right? So it is seen in children due to accidental intake of large number of due to accidental intake of large number of the iron tablets. Now, what exactly is the antidote of acute iron poisoning? This is a very important multiple choice question. The antidote of acute iron poisoning is desferrioxamine. The antidote for acute iron poisoning is acute iron poisoning is the desferrioxamine. And if you take this desferrioxamine, the route of administration of desferrioxamine is intramuscular route of administration, that is intramuscular injection. Now, apart from this desferrioxamine, DTPA and as well as calcium disodium EDTA may also be used, but your dimercaprol is contraindicated because its complex with iron itself is very toxic. So, apart from the desferrioxamine, the other substances which can be used is DTPA and as well as calcium, as well as calcium disodium EDTA. So, this may also be used, but your dimercaprol, whenever it combines with iron, the complex whichever is formed, the complex whichever is formed itself is very toxic. So, that is about acute iron poisoning. Then coming to the chronic iron overload. Chronic iron overload. See, for chronic iron overload, as in which clinical scenarios you will have this chronic iron overload? In those individuals in whom you require repeated blood transfusions, they may face this particular chronic iron overload, and this occurs in thalassemia patients. So, in thalassemia major, these patients, they require repeated blood transfusion. So, these patients of thalassemia major, they require repeated blood transfusion, and in them you need to give an oral chelating agent, and this particular oral chelating agent is deferiprone, the oral chelating agent is deferiprone. So, deferiprone is preferred. So, this is about the iron poisoning. So, this chronic iron overload, this can cause secondary hemochromatosis, and what is this hemochromatosis? Iron overload in the individual is called as the hemochromatosis, and this particular hemochromatosis, it could be due to gene mutation, that is HFE gene mutation, that will be your primary hemochromatosis. But if the iron overload within the individual is due to excess iron supplementation, and here the excess iron supplementation is in the form of repeated blood transfusion, and that will lead to that iron overload, that is called secondary hemochromatosis. So, acute iron poisoning is due to accidental intake of large number of iron tablets. Chronic iron poisoning is mainly because of your repeated blood transfusion. And acute iron poisoning, the antidote is desferrioxamine, and this route of administration of desferrioxamine is intramuscular route of administration. And apart from that, DTP and calcium disodium EDTA can be given, but the point is this dimercaprol, whenever it combines with iron itself, will form a very toxic complex. So that is the reason why your DTPA and calcium disodium EDTA is not being advised. And in chronic iron overload, that is usually seen in thalassaemic patients, and them you need to give the oral chelating agent like deferriprone is preferred. So this is about the iron poisoning. Now, after having discussed about the very important hematinic, that is iron, let me take up the discussion of folic acid and as well as vitamin B12.